Welcome. We'll wait just a few seconds here to let everyone join, and then we'll begin. Okay, welcome to the Healthcare Lounge. Today's topic is mental health parity, stopping the ticking time bomb. And we have guest speakers Jen Berman and Kevin Lee with us. So now I will turn it over to Nelson.
Thanks, Kendall. Welcome to the Healthcare Lounge. This month's topic is, and we use the word ticking time bomb, and I think it's really, really appropriate. And so to make sure you understand what's in store for your clients, what's at stake for your clients, if you are an advisor, if you're an employer, what you are facing in terms of the Mental Health Parity Act, we have with us two experts, one on the regulatory side, one on the clinical and solution side of mental health, behavioral health issues. Jen Berman, who is a brilliant ERISA attorney out of Baltimore, runs MZQ Consulting, and as many of you know, is the director of compliance for Next Gen Benefits Network, a tremendous friend of ours. And Kevin Lee, who is the founder and CEO of MindClub America, which is a one-stop shop concierge solution for employers to provide solutions around mental health, behavioral health issues to their employees. Kevin is actually out of Nashville, right down the road from me. And so welcome to you both to the Healthcare Lounge, Kevin and Jen. So Jen, let's start off with you and give us an overview of the Mental Health Parity Act. We've talked about it in the past, but I understand final rules were issued recently. Do you want your slide presentation up at this point?
We can probably we'll do without it. I think I'm just gonna we'll just chat. Right. Yeah. We'll just chat.
So what's the deal, Lucille?
So what's the deal? So the Mental Health Parity Act, not new law, right? So we have had mental health parity in some form or another since the mid-90s. And basically what it says is that employers have to provide mental health benefits in parity with medical and surgical benefits. So it's not as easy as all that. There's pretty detailed sets of rules and regulations there that say, all right, when we look at mental health, we're going to break it down into 6 buckets, as it were. And those buckets for these purposes are inpatient and outpatient benefits, in and out of network, emergency care, and prescription drug. And then within those 6 areas, we're going to look and we're going to say, are we essentially providing the same quantitative treatment limitations? And so for these purposes, quantitative treatment limitations are things like deductibles, copays, coinsurance, and the same non-quantitative treatment limitations, things like access to care, prior authorizations, formulary designs. So anything that might make it harder to get care for those mental health benefits as it is for those medical and surgical benefits. And so there's a whole set of rules around how we test if quantitative treatment limitations are in parity. And those are very, very technical in nature. And they look at actual claims data to see, have we met the rules for those quantitative treatment limitations? And then for the non-quantitative treatment limitations, there's a whole set of guidance around how we know are those non-quantitative treatment limitations in parity also. All of those concepts are old news, Nelson. They have been around for more than a decade. So why are we talking about this? Why did we just get a whole new set of regulations? Why is this a big deal? And why have I been running around for the past couple of years acting like it's new news? Well, the reason for that is there is a new requirement, and that new requirement was created by the Consolidated Appropriations Act of 2021, which came out at the end of 2020, And it's really the show your work requirement, or I call it a congressionally mandated book report. That's when Congress came and said that health plans had to prove that they were in compliance with the non-quantitative treatment limitations portion of that rule by creating a comparative analysis and documenting how they were in compliance with mental health parity. So it's not enough to just be in compliance. You have to prove that you're in compliance by maintaining a huge report showing how you are in compliance, both in writing, that your policies, procedures written down are in parity, and in operations, that what you actually do on a day-to-day basis is in compliance. And so just a few weeks ago, we got several hundred more pages of regulations documenting all of the detail around just that. Did I stun you silent? It's a lot. It's a whole lot.
All right, so break down there as I see it, and tell me if I'm wrong. An employer and their advisor have two areas of concern. One is what I think we call the paperwork compliance, which is something like your firm MZQ handles for employers, if I understand correctly. And then there is the plan itself, the plan components, the access to care, the type of services available, and all of that you understand and I don't. So can you break those two down? How much of the paperwork is it feasible for an employer to do? Is that something the advisor can do on their behalf? Is that advisable? So talk about the paperwork side of things for a minute.
It's interesting. So the final rule has this idea in it of a fiduciary certification. So it acknowledges that the paperwork and the creation of this comparative analysis, sort of proving that the plan is in compliance, is really, really hard. So it's one thing to design this plan to be in compliance and to put together a plan that is intended to be in compliance, but it is an entirely another bar to make sure that that plan in fact meets these standards. And so what this new final rule does is to create this concept of a qualified service provider that comes in and does the analysis to prove that compliance and to show and to do this comparative analysis. And it doesn't go so far as to say exactly who or what a qualified service provider is, but it contemplates that qualified service provider will certify to a plan sponsor that they are qualified to do a comparative analysis on behalf of a plan, and that a plan sponsor in their fiduciary capacity will select and monitor that qualified service provider to do just this paperwork on their behalf. So you asked, should an advisor be that qualified service provider? I'm going to go out on a limb here, Nelson, and say absolutely not. Right? So you would really need to be an expert in mental health parity to go in and really understand exactly the details of how all of these rules and regulations work. And they get into these concepts of factors and evidentiary standards and how exactly you design each non-quantitative treatment limitation and compare them to one another. So it's a big, heavy bar. But what an advisor can do and should be doing is helping that plan sponsor, who is the plan fiduciary, to find qualified service providers who understand that they now do need to be engaging in this process, making sure not only are they designing their plan in a way that meets mental health parity and its rules, but that they are also finding entities to do this analysis on their behalf, and to document that the analysis has been created. And then also complete a fiduciary certification to that effect.
Let me make sure I'm hearing you correctly, because I'm hoping I'm not.
Okay.
Is every plan sponsor required, expected, or advised to have this plan analysis done?
Sir.
Is that a yes?
Yes.
Okay. So I'll save this question for later. By the way, as you are listening to Jen and Kevin, if you have a question, don't wait until the end. Go ahead and type it in the Q&A box, and we will get to as many questions as we can. Go ahead and write it down when you're thinking of it. I know that I will think of a question and believe I can remember it. And by the end, when it's time for Q&A, I've completely forgotten my question. It was a good one too. So go ahead and enter those questions in the Q&A box. All right, Jen. All right, so that's the paperwork side, which, I'm reminded here of the pains of the paperwork pains around Obamacare when there was so much paperwork for employers to complete. And there wasn't necessarily expertise required or any sort of, validity around your what you knew, but you had to do the work. It was a lot of work. And then you add in the expertise aspect of it. Okay. Just a quick question. Is this a service MCQ provides?
This is what MCQ provides.
Okay. Shameless plug from my friend Jim.
I appreciate it. Yeah, thank you.
Well, they're going to have to go somewhere.
They do have to go somewhere. They do.
So if you're going to, you might as well start here. And if you want to go do some comparison shopping or what have you, but I can vouch for Jen Berman. All right. So that's one container. I won't use bucket because you've already used bucket. The paperwork and the assessment and sort of validation that the plan is in fact in compliance. What does the plan have to do to be in compliance in terms of services and procedures and information and access for employees to mental health services?
So that's an excellent question. And I will tell you, having done hundreds of these analyses at this point, that sometimes we find that they're not in that process. And that's why we have to do the paperwork. But they need to be providing these benefits in parity. So the most important piece of that is that making sure that whatever sorts of treatment limitations they put in place, they're putting the same thought and same types of restrictions on access for those mental health and substance use disorder treatments as they are for medical and surgical benefits. So if they're going to put a restriction, let's use prior authorization as a simple example, that the same factors and evidentiary standards are used in developing, or comparable factors and evidentiary standards. They don't have to be identical, but they need to be comparable in developing the reasons for that prior authorization standard for mental health and substance use disorder as for medical and surgical benefits. So when we're doing an analysis, we walk through those things, and we would have to also walk through those things in comparison on both sides of the house. So you have to comply with the underlying law in addition to showing that you've complied with the underlying law. And there's lots of things that we find as we're looking at this process, sometimes in writing, right? Sometimes we find the written policies fail because there is a prior authorization requirement, say on access where we don't have the prior authorization requirement on medical or surgical. But other times we'll find that the limitation or the problem is on the operational side of things. So we have the same rules for both medical and surgical as we have on mental health and substance use disorder. But when you actually go and look at the data, how many times was the prior authorization, or what percentage of the time was the prior authorization denied? You get wildly different percentages. That's also a parity failure. Maybe looking at something like exclusions. And if you look at the exclusions, you find significantly more exclusions um, on certain mental health related items. That can cause a parity failure. So you can find them in the plan design. You can find them in the plan as it's operated. And so it's really a holistic evaluation of the plan, how it's written, the actual design of the plan, and how it's operated on a day-to-day basis.
Okay. Let me turn to Kevin. Kevin, welcome to the Healthcare Lounge. Delighted to have you in with us. Your first time. We're gentle.
Thank you, Nelson. Good to be
Kevin,
here.
so everyone knows, I say everyone knows, Jen's background, JD, MBA. She has a master's in medicine. She is an attorney. You want to give a little bit of your background in behavioral health to sort of set the stage for the conversation that I want to have with you around helping employers provide the services in a way that make sure that they're compliant with Mental Health Parity Act.
You got it. Yeah, I'm not a clinician, but I've been in behavioral health for over 30 years. It's my whole career. I started at Ernst and was hired away by a client psychiatric hospital company. And that company owned 10 psychiatric hospitals and various clinics. Was sold. I started another one. So I'm on my 5th behavioral health startup and have covered the scope of services, if you will, being psychiatric, inpatient, outpatient, addiction treatment, residential, outpatient. I think I've signed leases for over 80 clinics and about 20 hospital properties. So I've seen a lot. And the Parity Act is interesting. It started because Pete Domenici, a senator from Arizona many years ago, and I believe a daughter had schizophrenia, and drove him to start the whole parity movement. Jen can check me on that, but I believe that's right. It took someone hurting to create this. So
I will. Pete Domenici, if I'm not mistaken, was senator from New Mexico.
Oh, was he? Sorry.
I think
but
so.
What's the difference? No, I'm kidding.
Well,
he may have been from New Mexico. Sounds right.
we try to be accurate. Well, interestingly, I've got something I want to bring up in a few minutes that originated in New Mexico.
Yeah.
So that may be appropriate. All right. So, Kevin, what are you seeing where are you seeing employers struggle in terms of providing mental health? And I don't mean just therapy. That's what everybody thinks. So they need a therapist, counselor, but there are other services, there is other information available. Where are you seeing employers lack? What areas are you seeing them lacking?
Most often the discussion that is in response to that, what are employers struggling with, Nelson, has to do with access. And access to quality, reasonable services. So often we see folks who have addiction problems jump over state lines, and the employers spend a lot of money. That's a real struggle for them. That's the big issue. Do we have available services that are quality, outcomes oriented services available to employees? We hear a lot about the needs in remote areas. Well, I shouldn't use the word remote or rural, but maybe an hour away from major city, people having access problems. And that could, in my opinion, affect compliance with the parity rules.
Jen, are you nodding on that? Would you agree with that?
I am nodding on it. So one of the areas that we look at for parity is network adequacy, and finding one of the things you have to look at is sort of how many providers you have within an urban area versus a rural area, and many plans fail, particularly in rural areas, because of the inability to create a significant enough provider network.
Yeah.
So in those in-network categories.
Yeah, and it seems like you're hitting on an issue that I've been concerned with for many years, and that is if an employer or the health plan causes an employee to pay a higher coinsurance by virtue of going out of network, they may not have ready access to in-network. And that's a real big problem if you've got a person with a combined alcohol abuse and depression issue. That to me is a parity challenge. It really is. I'm not sure how that works within the rules. I just see it as an issue, that access problem.
Well, I think it, an obvious violation would be limiting the number of therapy sessions, unless you're limiting the number of infusion treatments for a cancer patient. Jen, am I right on that? That's that, but that's
that's the other side of the rules. That's the quantitative treatment limitation rules. And that is sort of a facial violation of the quantitative treatment limitation rules. And there, it's not even like unless you're limiting the number of cancer treatments. So when we do that quantitative analysis, we have to look at those things by bucket, right? So you can't do any limitation of anything, for example, any outpatient mental health treatment, unless that limitation exists and is the predominant limitation for the entire category of outpatient medical and surgical benefits.
Yep.
So it's not just looking for like one comparable example, it's the whole category.
Yeah.
So that seems a fairly obvious and egregious that we're limiting care, but the access is effectively the same thing.
Right. And
oh no, we're happy to pay for as many therapy sessions as you need if you can find a therapist. And if you can't,
hit exactly there on what we're talking about when we're using our legal mumbo jumbo on the difference between quantitative treatment limitations and non-quantitative treatment limitations. The quantitative ones are sort of easy to wrap your head around, but non-quantitative, that's why we have this whole big paperwork requirement about the non-quantitative ones, and why the Department of Labor and HHS, because this is a rule that applies to governmental plans and non-ERISA plans as well, are so focused on the non-quantitative.
So let me give you a question real quick, Jen, while we're on that, from Terry Shook. What data, Jen, do you need from a plan sponsor to provide an analysis?
Oh, it's a lot. It is, unfortunately, it's a big ask. We have multi-page requests that go to both the plan sponsor, their TPA, their utilization management, their PBM, collecting a whole bunch of information about their written policies, as well as detailed information. It doesn't go all the way down to participant level claims information, but things like what percentage of those prior authorizations are denied, which percentage are denied on appeal. But there are 5 different sets of documents that go out, again, to each of those different components of the plan, asking a lot of questions, because the average self-funded plan has about 15 to 20 non-quantitative treatment limitations that have to be analyzed.
I'm sitting here looking at the questions that are coming in, and probably 2/3 are related to access.
Mm-hmm.
So, Kevin, you have experience. I remember correctly, you have experience building networks in the past.
Absolutely.
All right. So, and the plan is responsible for accessing a network to provide access. Jen, correct?
Mm-hmm.
All right. All right. So some of the questions go to the availability of of providers in remote or rural areas, Kevin? And does virtual provide a reasonable solution to that? And so I'd ask Kevin, I'd ask you your experience with that, and then Jen, your whether or not it meets the litmus test.
Virtual is certainly a solution, and I believe it would. I'll leave it to Jen to respond to the mental health parity compliance. But virtual is a solution. Let's take an example. If someone is in Russellville, Kentucky, an hour or so less away from Bowling Green, and that person whose feet are on the ground in Kentucky can see a provider licensed in the Commonwealth of Kentucky virtually and comply with the requirements. That's my opinion. So they've got access, and that works, and that's what we do. So we provide a roster of clinicians that meet the needs of the consumer, and telehealth should meet the compliance requirements. I'll leave it to Jen to respond to that, but I believe it will. We do.
So one of these wishy-washy lawyer, it depends sort of answers. The answer is the Department of, and that this actually there is an answer to this in the final regs that just came out. The department is not going to say that virtual fixes the problem. What they're going to say is if your network is inadequate, you have to actively work to fix it through things including looking at your rates and your reimbursement rates, et cetera, and adding virtual providers to your network. So they're going to look for a holistic approach. So it's not going to be simply enough to say, all right, we're going to put in telemedicine and be done. But telemedicine will be looked at as a component of a full, holistic, good faith effort to build out an adequate network. And they're pretty specific about that in the final reg.
Okay, Kevin, in terms of providing a network, I know that is MindClub America, which is your solution for employers, includes gamified educational modules on all manner of mental health, behavioral health issues. It's got assessments, free assessments to the employees. All of these services, in fact, are of no cost to the employees. But the real issue, I think, is access to and some problems can be solved with education, perhaps, but the real need seems to be access to a counselor. So how do you build a network, or you have a network or build a network as you're going into a market?
Right.
How does that work? How quickly can you set up? Because I know you're not in fairly new company, not in every market. How quickly can you get a network set up, and how can you be sure that you're providing quality counselors, and what kind of price are employers going to have to pay?
Yes, we can generally stand up a roster of clinicians who are coordinated and in a group practice within a couple of months. It may take 3 months. If we go into a state, we can be providing services in up to 3 months. It might take 2 weeks, depending on where it is, what state. It may take 3 months. But we will have a credentialed group, including a psychiatrist, psych nurse practitioner. Usually a primary care physician will also be involved with us, and they can evaluate and prescribe medicines. And then we'll have a roster in that same group of licensed clinical social workers, licensed professional counselors, alcohol and drug counselors, who can do, as you said, provide the mental health counseling and medicines management for someone who has anxiety, depression, substance use challenge, whatever it may be. And we do this so that the employer onboards us with the employees through a information awareness campaign. So the employees have our phone number. They can call us with total anonymity. They call us and we'll respond. If the person is acutely ill, we can determine that quickly. get them to a psychiatric hospital. We don't operate psych hospitals, but we can make that work. We charge what you would call in-network rates. So depending on how the plan is constructed, it would be equivalent almost always to an in-network rate. For example, in Tennessee, it's $102 to $108 for a 1-hour counseling session.
That's the full rate to the employer, to the payer?
To the plan, that's correct.
Is
Yeah.
there a copayment?
There is a copayment in almost all the plans. We advise employers to pay the copay so that the employee or covered family member has no out-of-pocket expense for their mental health services. If we can structure it that way, we've got a winner, because we know, generally speaking, that about 8% of the total healthcare dollars that go out are direct mental health services. But those services affect almost half of our total healthcare expenditures. Example of that is a person with long-running chronic depression is twice as likely to have a cardiac problem, heart problem. And if we can manage the depression, and we can, we're less likely to have that person have heart failure, end up in a hospital costing tens of thousands of dollars.
Well, speaking of copayments, New Mexico passed a law prohibiting private insurers from imposing cost sharing on behavioral health treatments, based on a study that examined perspectives of clinicians, insurers, and state officials. And it showed that that the copay adversely affected utilization, access and utilization to the services. Now, that's one state, but I've noticed with the background in public policy and working at the state level in policy, I can tell you that it's a follow the leader mentality. And once somebody does it, if it has any efficacy, makes sense, especially if it's revenue neutral to the state government, they'll pass it. So, Kevin, any thoughts on that New Mexico law? And Jen, are you familiar with that? And do you think something like that may have legs?
Well, first off, I love it, and I'm anxious to hear Jen's thoughts as well. I think it's great. It seems like it's a violation of the parity rules in a way. I mean, let's think about that for a minute. But what's so important with what New Mexico is doing, in my opinion, I hope I'm fully informed on this and sharing my thoughts with everyone. It highlights, it emphasizes the importance of access to mental health services for the citizens of New Mexico. It's a big win for them.
Now, by the way, this state law does not affect self-insured plans because they are not subject to state regulation, but rather ERISA.
Regs. Yeah, I saw
but
that, yeah.
But it's the principle of the thing here. Jen, what are your thoughts?
I mean, I wouldn't see it as a parity problem because it's obviously more favorable to the mental health benefit than to the medical and surgical benefit. So that I think would work. And it would only apply to the fully insured plans in that state. As far as the policy is concerned, me, Nelson, I don't tend to comment on policy itself. So
no,
I'll leave that. I'll leave that to you and Kevin.
Yeah, when I said the parity challenge, and I'm glad you said what you said, Jen, what I meant was it seems like it was a flip, because a surgical patient might be paying and doing the cost sharing thing, whereas a mental health patient is not.
Yeah, exactly.
All right. So, Kevin, in terms of, and I'll give you a little shameless plug here, MindClub does provide this broad range of educational and support services at no cost to the employees. There is a really interesting program you all have set up, you told me about, to help parents of teens deal with the vagaries of teenagers as they grow into adulthood.
I have two.
Well, Jen, you might be interested in this program. It is for parents who have issues with their teens because the communication issues occur. They start to assert themselves in ways that don't conform to parental standards.
Yeah.
Hard to imagine. Not in your household, I'm sure.
Probably not.
But the MindClub does have this program that is basically a community with programming for those parents. And there is a slight fee to the parents for that, not on the plan,
Right.
just on the parents. But I think it sounds to me like the big thing that MindClub does is provide this network and provide access. Now, when you say access, I'm an employee. I call the mental health, the behavioral health number that puts me in touch with MindClub. And let's say I say I'm really depressed, and I'm offered a no cost depression assessment to take. I take that. I get talked to your concierge, and they say, you might want to talk to somebody. I'd like to talk to somebody. How many weeks are we talking about before I get to talk to a counselor?
Almost always within 2 days. Now, if you call us on Friday afternoon, it might be Monday, but oftentimes we'll see these folks over the weekend. Very often, we
So
make
2
ourselves
days, not 2
available.
weeks.
2 days. That's our rule. Oftentimes it's within a day, and we'll get some calls that seem to be urgent. We don't know if the person is having suicidal ideations, but we'll see them quickly. What MindClub was founded on for several purposes, but the primary purposes, and what I learned over the years of being in psychiatric hospitals, clinics, and so forth, as outlined earlier, having seen the scope of mental health and addiction treatment services, was we need to provide super easy access, which is hard to do. That's the hard execution part, and with a focus on outcomes. For employers, we want employers to get these results, and that is, we improve the mental health of the workforce. 1 out of every 6 employees, wherever they are, is affected by a mental health condition. Their productivity is affected. So we want to improve the mental health of the workforce, and over time reduce the healthcare expenses for the employers. And we can do that. We reduce employee turnover and missed work days. But the 2 keys are, we improve the mental health, therefore we save the employer dollars. So it's a super quick access, which is hard to do. That's what we execute. And then we get outcomes like I mentioned. And in order to get those outcomes, and thanks for mentioning it, Nelson, we have an e-learning library that is rich with resources that are free to employees. So if XYZ company says, okay, MindClub, we're giving your number out, your website, we're going through the onboarding, we're giving our employees all the awareness information. That means that all the employees and their family members have free access to anxiety deep dive, managing my depression, cognitive behavioral therapy. We want them to be healthy. We want outcomes. We make our money through the mental health counseling, medicines management, where we just get a markup on the therapists or physicians, nurse practitioners. And then parent inner circle, Nelson mentioned, which is really important. I believe this physician was from New Mexico who started the program. His last name is Meyer. I don't know him. But 30 years ago, it's been proven to work over and over and over again. It's called the Community Reinforcement and Family Training Program. CRAFT is the acronym. And we use that. And parents access that program, pay us a subscription fee model. We'll discount it for some employers. It's not expensive for what you get. Parents who have a struggling teenager or young adult struggling with anxiety, substance use, and the parents, and there's a gazillion, I like to say, parents out there with that challenge, right? We provide a resource that works for them. What do the parents get? They learn how to set boundaries and communicate with their teenager, young adult, be the hero to them, gain confidence in communicating, and everybody wins. You've got a healthy family if you go through the deep dive program, which takes 12 weeks, and you can come in and out of it You attend online sessions, you get access to one-on-one coaching and a lot of learning materials. It's very effective. It's wonderful.
Jen, I know the access issue comes to the fore. These other services, these are not particularly, they don't particularly register mental health parity, do they? Like the educational pieces, the coaching, that sort of thing?
They don't. I mean, they're certainly bringing value, but they're not directly related to the mental health parity issues.
Okay, so we're talking access. So there are two really good two questions here, very related. I'm just going to combine them. If no providers within a certain radius, how's an employer supposed to resolve this? They can't force clinics to establish services in your area, which is critical for remote locations. And the next question, if providers resist joining a network, how's the plan responsible? Fewer providers in a rural area. Again, how's the plan responsible? And Kevin, you're saying it's not really, no one expects the employer or the advisor to be solving this problem. This is a solution provider issue, like what you do at MindClub, right?
That's right.
I mean,
we'll solve it for them. And again, going back to the telehealth discussion we had previously, we will solve the problem because we'll have a licensed clinician appropriate for that medical need in that state. And as Jen mentioned, telehealth is not necessarily always the answer, but my argument is for that level of service, if the person does not require that in-person visit, then telehealth should be sufficient. Again, I'm not trying to play lawyer, but we do solve the problem. MindClub does that.
Okay. And Jen, you can chime in on this too, although I don't know that there's a lot. I mean, you're just Joe Friday, just giving us the facts, or Joe actually asked for the facts, but nonetheless. But Diana Stewart has a great question here. Sounds like a nice feature, and I think she's talking about mental health parity overall, but employers still pay a cost as the overall cost of the health plan would increase. So they might end up paying, employees might pay a cost because the health plan costs are going to increase, and thus premiums in the long run are going to increase. Basically, this is going to contribute to medical inflation. Kevin, so the prices that employers pay for a counseling session under MindClub, with your network, how does that compare to, let's say, a Blue Cross reimbursement or a Cigna reimbursement?
We would compare be about the same. It is. It's those in-network rates that we charge, the same as Cigna, Blue Cross. If the employer is working through a third-party administrator or directly with one of the BUCAs, the rates that we charge are equal. And so the question is, if we double the access and the employees are getting twice the number of outpatient services than they did the year before, short term, those health plan expenses will increase. But I'll argue, because I know I'm right, that it's proven that over time we will drive down overall healthcare expenses. We know that it happens. And
the immediate cost of counseling, of mental health costs go up, but with the benefit of a reduction of overall medical costs in the mid to long term. So how much additive to a plan is, if an employer wanted to, or an advisor wanted to put MindClub in, what sort of load are you putting on the employer? How much are you charging?
In the range of $20 to $30 per covered life per month, which is really
no, but I mean in terms of if they want to implement MindClub.
Oh, nothing. Just implement us and make us available at $0. Nothing.
No cost.
No
so, PPM.
Right. We can evolve into a PM per employee per month and share risk, which we want to do. And that takes a little time. That takes a year or two with an employer. We get a little history, or even with an employer that's been around a while and has a pretty stable plan, we can go at risk day one. But
Okay,
I
but
think the
let
primary,
me go back. No, that's down the road.
Yeah.
So an employer that or an advisor wants to put MindClub into a group, there's no cost to the employer until an employee schedules an appointment with a counselor.
correct,
And that's done at an in-network rate.
correct. Yeah,
So,
we're only,
so if they're using the access here, they're not going to be using out-of-network providers that are $180, $200 a
yeah,
session.
not unless they pay for it, the consumer, the employee, family member pays out of pocket. And I want to go back, that's right. And I want to go
Okay.
back and add a little clarity, because that question, yeah, we will, if we double the utilization of mental health services in year one, outpatient expenses will go up. But during that time, we're very likely to reduce psychiatric hospitalizations and residential addiction treatment. Very likely. And those are big ticket items.
Okay.
Very likely. Yeah.
Okay. Wow. All right. So that's encouraging, because I see a lot of pressure on the employer. We're talking self-funded plans now, on the self-funded employer to ensure access. It's like, well, how do I do that?
Mhm.
And you would think, oh, well, I'll have to find a network at $17, $10 PEPM to be able to access that mental health provider network. But you're saying no upfront cost
Right.
for the employer.
No.
Okay. All right. Wow. Kathy Aiken asked, when does a comparative analysis need to be done?
Well, technically they were required by February of 2021. Now, I'm aware of the fact that most plans did not have them done by February of 2021. The fiduciary certification requirement that they are done. So fiduciaries have to certify that they've been done by a qualified service provider by January 1st of 2025. I'm going to go with as soon as reasonably possible. The better question to ask is, when might I be asked for one? So the Department of Labor has the right to ask for one upon request, or CMS for non-ERISA plans. If the Department of Labor asks for it, you have to produce it within 10 days. And they're pretty strict about that now.
How long does an assessment tend to take?
6 months.
All right. So a 6-month analysis needs to be provided in 10 days.
Correct.
Okay.
Now,
well, that works.
Yeah, exactly. So that's an issue. Now, Nelson, what's the likelihood that the Department of Labor knocks on your personal door? Well, there's actually a lot of MHP investigators at the Department of Labor. MHP accounts for about 25% of the Employee Benefit Security Administration's enforcement budget. So higher than anything else. And when I say 25% of the Employee Benefit Security Administration budget, I mean the entire budget for all employee benefits, which includes retirement plans. Still relatively low. Want to know what the really big risk is?
Oh, stop. Wait. I've got to ask a question first, because I want to give Michael Smith credit for asking the question. So stealing a little bit of your thunder, but
it's okay. I saw the question. It's a great question.
You have so much thunder. I'm not worried about it.
It's so good.
Can't be the nun in the whorehouse until plan sponsors fear litigation. Is the tort bar showing any interest in pursuing things like this, like or fee disclosure for that matter, like they did in 401k?
Yes, Michael, they are. And in fact, there are more than 5 times as many lawsuits in the mental health parity space as there are in the fiduciary space. And you know how much we've all been talking about fiduciary cases. The real risk is that you have a participant or a participant's lawyer ask for one of these, and participants are entitled to the comparative analysis.
Plan participants. In other words, your employees. on the plan.
Your employees. And guess who knows all about this? The activist groups.
Oh, the mental health activist groups. There's a whole cottage industry here around this. All right. So it seems to me, Jen, that the big, obvious, glaring, open wound that employers are sitting there with is access. That's like the big one that has, I mean, it's so noticeable, and it's going
Unless you
to.
have an ABA exclusion in your plans. If you have an ABA exclusion in your plans, get rid of it now.
Okay,
Just
ABA
say.
exclusion, you want to clarify?
Yeah, if you exclude access to ABA, applied behavioral analysis therapy, that is a violation of mental health parity, and Autism Speaks is coming after you. I'm not kidding. Usually free advice is worth what you pay for it, but on this one, trust me.
Okay, so you have raised a really interesting point. There is effectively no difference between fiduciary responsibility and compliance with mental health parity. They're both imperatives. They are both mandatory.
Correct.
The difference is there are no activist groups on fiduciary.
Or the extent that there are, they're really kind of tiny, and they don't really have to do with taking care of your
You don't
children.
have activist groups, you have activists.
You have activists, some
Right, you have a
small
few
activists.
activists,
Correct.
but not national networks of parents whose children are ADHD or have or on the
Or at
spectrum
risk for
autistic.
their lives. I mean, these are serious issues being handled. These are not, I mean, yeah.
Okay, so that's a pretty open sore as well. But I think the one that has the broader implication for the broadest set of employees is the access issue. Would you agree,
Yes,
Jen?
yes. Sorry, I went off on a little tangent.
No, that's
Yes.
okay. No, it's a
Yeah.
very, very valid point, because it's a hot issue for the people and for whom it's a hot issue. All right, Kevin, any thoughts as we finish up here around advisors? We have a lot of advisors on the call, and some employers as well. Any advice to them in terms of how to deal with this, and when to deal with this? Is this, do you think it's a pressing issue, or it seems to be a pressing issue?
I think it's a big pressing issue. And Nelson, thanks again for having me and asking that question, because if I'm an advisor, I want to know if my employer clients are pleased with the mental health services available. Do they know that their employees and covered family members have quick access to quality mental health services? Are they getting the care they need? We know in our country that 1 out of every 4 adults, you could say 1 out of every 5 if you want to, has a mental health condition that needs attention. They need treatment. Half of those people get treatment. Many of them are employed. So it's that access. If I'm an advisor, I really want to know how pleased the employers are, and do they know? Some of the employers don't know. So.
All right, couple of questions, Jen, for you as we're finishing up here, and Kevin, thank you. I'm really impressed that this is something available to employers at no out of pocket, no upfront investment. Because I know the access issue is real. And the other thing too, and Jen, I know you're aware of this, but and I just use the word aware because I'm going to use it again. Awareness of behavioral health, mental health issues since COVID is through the roof. And I think it's not, maybe COVID caused more, but I think there is a certain introspection that occurred. So many people were sitting at home going, you know, I'm not very happy and I don't have work to distract me, or I don't have the office to distract me, and I'm depressed, or I'm drinking too much, or whatever the condition is. I think and everybody went back to work, back to the office, if they went back to the office, with that awareness. And now they're living with it and they're conscious of it. And that to me is, I think, what employers are seeing, that their employees are no more depressed necessarily than they were before COVID. It's just that they're conscious of it. They're living with it and aware of it. And they want solutions. They want an answer. They don't want to be depressed or anxious or drinking too much or drugging too much. A couple of quick questions, Jen, for you with a few minutes left. Pam Long asked, do you expect fully insured carriers to provide this for the employer?
So expect fully insured carriers will be taking care of this requirement relative to their employers.
Okay. We'll see how that happens. And then I'm just
Let me
thinking,
rephrase. I think they're required to do it in the shared
they are.
liability.
I'm just thinking about network.
Well, yeah, no,
network.
it's not. Yeah, I'm just shared
because
liability. Yeah,
they've got a network now, and it's inadequate in a lot of areas.
Let me put it this way: I don't think fully insured employers need to worry about it.
They don't. No, they don't. I'm thinking though of the employee. Kevin, do you have any fully insured employers using your network and your program? Any employers that are fully insured?
No, all the employers we've got now are using no.
So all of your clients are self-insured.
Oh, I'm sorry. I'm answering you the wrong way. I'm thinking about them. They are all using Blue Cross, Aetna, Cigna right now, and we've got one pending with United.
Okay. So Diana Stewart comes back. Diana, thanks for your participation today. Regretfully, we're seeing fully insured carriers are not completing the assessment on behalf of the employers.
They're the ones legally responsible for it, though. So the liability is going to lay with the
carrier.
With the carrier.
Okay. All right. And then finally, Barry Bender says, so to be clear, are you saying that plan sponsors aren't necessarily obligated to provide some kind of annual report or compliance attestation to a federal agency, but rather to be ready to demonstrate compliance if you are ever audited? In other words, it's a defensive response, not an offensive response, correct?
There's no filing requirement.
So you need to have this on hand.
You are required to have it on hand.
Okay. All right. We are at time. Kevin Lee, thank you for joining us in the Healthcare Lounge. Jen Berman, as always, a pleasure to have you with us. Thanks for bringing your expertise. And Kevin, thank you for sharing your expertise and experience and what you're doing at MindClub. Jen, how do they contact you or MZQ if they're
Engage, ENGAGE at mzqconsulting.com.
Engage at mzqconsulting.com. Engage as ENGAGE. And Kevin, how about if they're interested in talking to you about MindClub and your network and services?
Absolutely. MindClubAmerica.com.
MindClubAmerica.com, and then they can get to you from there.
They'll get to me. Absolutely.
MindClubAmerica.com.
And all right. I hope I get 36 or so, whatever, inquiries.
Well, here's to that. Yeah, all right, everyone. Thanks so much for joining us. Thanks for being our guest today, Jen and Kevin. And we will look forward to seeing you next month in the Healthcare Lounge.
Thank you.
Thank you, Nelson. Thank you.